on, and I cannot wait to get started on this really essential, vital conversation about hello. It's so wonderful to be with you. We've planned a long time, and I'm really looking forward to this conversation.
No, me too. Me too. How are you?
I'm doing well. Well, thanks. I'm Catherine Hansen. It's a real pleasure to meet you. And how do I say your first name?
It's Siobhan.
Siobhan.
Siobhan, yes.
Okay.
Yeah. It's spelled a bit strangely.
Okay, well, no, it's beautiful. Beautiful and beautiful. So I'm going to try really hard, Siobhan, to say that. And just excited because I know that you're an author, and I've been watching what you've been doing on Instagram since we first connected. And just again, really excited. I'm again Catherine Hansen, with the head of Pandia Health, and I do their head of menopause. Actually, we do contraception and menopause at Pandia Health, but I'm also an obstetrician and gynecologist. Women's health is my passion and purpose, and I would love for you to introduce yourself as well.
Yeah. So my name's Siobhan. I'm now 36. Trying to think how old I am now. 36. But when I was 31, I realised that I had gone through an early menopause, and I was diagnosed with POI, primary ovarian insufficiency, which was something that I hadn't actually really heard much about. I'm a doctor as well, so I've been through medical training, but it's still just not something that I had any awareness of. So it was quite a shock, but I've learned a lot over the last few years. I think it's taken me a while to come to terms with it, but now kind of come to terms with it, and I'm trying to just move on in life and make the most of it as much as I can.
Yeah, and so thank you for that. And you're not just moving on with it. I mean, you're educating, you're bringing people into, greater understanding and awareness of what's happening in their body, and you're an author. You're writing and educating, and I have such deep respect for that. It's really inspiring to see you take, what was probably a shocking and heartbreaking story that you experienced, and helping others, know what they can do and how they can reach out, and ways that people can support each other. Literally just yesterday, I was in clinic talking with a woman who had a similar story, and one of the biggest things, and we'll get into this, I'm sure, one of the biggest things for her was just being made to feel like she was crazy and gaslit, and really very little compassion in a lot of her medical appointments. And so I welcome your sharing of what that was like, both sides, the medicine side, patient side.
Definitely.
Hear a little bit more about your
Well, I think that's what inspired me kind of to write the book in the first place, because when I found out, I think I shut down. I ignored it because there wasn't the help there, and there wasn't the support, and there wasn't really much information given. So for a number of years, I just kind of ignored it. And then it was when I realized that not having POI, it wasn't just, it affected me for other ways. Going through the menopause means that you've got an effect on your heart, your bones. And I was like, I need to take this seriously. But there was nothing out there. So I was like, if I could just write something, it's just so that there's a point of reference for people when they're diagnosed, even if they can just pick it up. And I think I'll stress by saying at the start of this, everybody's journey is very different, and everyone's got very individual, and there's so many different aspects to all of this. And people go through early menopause because of diagnoses, new diagnoses. People go through it because of cancer. People go through it with autoimmune. There's so many different, so you're dealing with all of those things in the background on top of like an early menopause as well. And then on top of that, you've got the fertility side of things which are thrown in. So I think it's really hard because it encompasses so much. It just has such a big impact on people's physical and mental health. I just can't believe that more noise hasn't been made about it up until now, because there's so many women struggling, and there's no one listening, and they don't know where to turn.
Right. No, you're absolutely right. And just to kind of organize some of what you just said, so much that, in that short frame, some of the causes, and the vast majority of the time we don't causes POI, premature ovarian. They say 90% of the time it's idiopathic, meaning that's what the medical field does. They don't know how to say I don't know. There's not a lot of humble in medicine, unfortunately. Sometimes genetic, sometimes, as you say, autoimmune. And I believe, just in what I've seen, autoimmune, all diagnoses in the autoimmune sphere seem to be increasing in the current environment. And then cancer, chemotherapy, radiation, pelvic injury, various forms. And so those would be sort of the causes that can be worked up. And that's why it's so important for women to know that it is important to come to help. And I'd love for you to elaborate on, how common you are seeing. Probably a lot of people come to you for support. So how common do you think this is? And what kind of, other than sort of the straight medical diagnoses, what kind of things should people be watching for that should bring them to care?
So I don't think we know how common it is, and I still really believe that there's so many people who, I think the latest statistics are it's 1 in 100 under 40 and 1 in 1,000 under 30 have POI. So that's just POI. That doesn't encompass all of the autoimmune stuff. That doesn't encompass when you've gone through the cancer. That's just POI. But that's who we know about. So I think they've already said that they think that that's now 4 in 100 or something. So they think that statistic's already gone up. And there's just so many women who will be out there who don't know how to find the words to speak about it, are ashamed. Maybe their family won't feel like their family won't accept them, their friends won't accept them. So I think that it's one of those things that there's probably so many more women who've gone through it, who are going through it, but we still just don't know. And there's such a stigma around it, and there's such a stigma around things like the infertility. I think that was my biggest fear at the start, because I was diagnosed when I was 31. So I'd recently come out of a long-term relationship, and I'd been on the contraceptive pill, and I let that slide just because of what had happened. And then I started getting things like the hot flushes. So that's what sought me to go and see somebody, get some blood tests. And that's how kind of my story unraveled. It was the contraceptive pill hadn't caused it. And I think that's a big myth as well. People think that can cause it. It can't. It's just that it was masking the symptoms because I was getting the estrogen, so I wasn't aware. So when I found that out at 31, I think my main worry was like, oh gosh, fertility. But at the same time, because I'd just come out of a long-term relationship, I wasn't really in a place to think about that. So I was just trying to kind of bury it and not really think about everything. So fertility is a massive side. And I think that's also why I think sometimes where people don't, because if you're on a fertility journey, I think that's very all-consuming, and I think that's it's hard to take. So I think that possibly people don't worry about some of the other stuff when they're just focused on their fertility. I think some people are probably quite embarrassed about that as well. So I think that would stop people from maybe speaking out and sharing their stories as well, which is a shame. So I think that's a lot of society's kind of created that.
Yeah, society's created a lot of things for women to feel ashamed. I think if there was any way we can kind of crack it open that and release that, I mean, our lives, women would be so much freer and liberated. I know that that's the work you do, and it's certainly the work that I would love to be able to say that I do as well. I just appreciate your expressing how hard it was and what those challenges were. And I think adding to that, some of the intergenerational challenges, like what I've seen is, our moms didn't necessarily talk with us about that. Our grandmother didn't necessarily talk with us about that. And so we do see some genetic component, like my through menopause at 39 or 41. And so I feel like I shouldn't be, but I feel like I am. And so we don't know, we don't have support except with people like you and people who are willing to start sharing their stories so that we can feel a little less alone. And I want to, you talked about blood tests. And I'd love to go toward the fertility conversation because it's such an important part of POI, and there is treatment. So let's create some hope around the conversation. But do you want to talk a little bit about symptoms or what people may be noticing that think they're not crazy, but they need a workup?
Yeah. So it's hard. So the main thing that triggered me to go and get my blood test was the hot flush, but it still took me a while because I'd just come off the contraceptive pill. I just assumed that it was something to do with that. I was like, well, hormones are probably everywhere. So I didn't really think too much. And then even when I got my first set of blood tests back and they said they were abnormal, I just again didn't, because the doctor who spoke to me didn't really stress very much. They said, oh, they're abnormal, we'll get some more. I don't think anything had gone off. And it was only when I went back to have a smear test with a more experienced female GP, and she brought it up again, and she was like, oh, have you seen your blood tests? I'm quite concerned about them. And I was like, oh, they're fine, you're just abnormal, I'm getting some more. And she at that point was like, no, I'm referring you onto the I think the words were premature ovarian failure clinic, which I know is an outdated term that we're definitely moving or trying to move away from, because it shouldn't, it's just not a good not a good term of phrase. But yeah, so she was the one that referred me on, because I think it was my FSH that was very, very high, and she said, I've never seen it this high in someone your age, so I think this is important to kind of get seen. But yeah, that in that sense, that all happened quite quickly, that period. So I think that's probably why I didn't process it very quickly at the start. And I know from that side of things, I'm very fortunate, because I speak to so many amazing women who've had to be knocking down the door of the doctor because no one's listening to them and no one's believing them, and no one's listening to anything they say. And I've got friends as well who are starting out GP, and they don't know anything about this. The medical professionals aren't taught about this. So it's really, really difficult.
Yeah, thank you. And I'm sort of reading a couple comments. See all the comments you have, Pandia, moderate. People can.
Sorry, Alexa, stop. I'm really sorry.
No worries. This is real life, real Instagram. But people put questions in I just want to encourage people to put questions in and comments, and we'll come back around to answering some questions toward the end. And I did notice someone typing in there, they're from Mexico. They were diagnosed at 25. It was really confusing and, really challenging. And so, again, this is not something that people should feel isolated or shamed. It's not a failure. We're really trying to get rid of premature ovarian failure. Used to be PFF, now it's insufficiency. And there's, a continuum, right? Like you described hot flashes, some people will have hot flashes and night sweats, those typical motor symptoms. Some people will notice, just really vague symptoms, which makes it even harder, aches and pains, skin itchiness or rashes, hair changes, mood instability, depression, vulvar changes, vaginal changes, pain with sex, dryness, all of these things. And one of them alone probably not enough to figure it out, but the whole constellation is need to be addressing.
I remember when I was at medical school, because I don't know when exactly it was that I went through it, because obviously I'd gone through it by the time I kind of got diagnosed. So then you kind of start looking back and thinking, oh, well, I wonder when it happened. And then you start trying to piece together and match up with all the symptoms. And I remember going through a period at medical school when I was going to the doctor. I kept going to the doctor because I was getting UTIs and everything down there was very dry, and I was just I thought I had thrush, and I kept going, and they were giving me things and it just wasn't getting treated. And every time I went, it was kind of, well, we're giving you this, like, what do you want to do? And I just felt in myself, then you just feel really dirty and you just feel awful about it, and you start to kind of hate on yourself. And I look back now and I was like, well, no wonder that I was getting this. I wasn't having the recurrent UTIs. I didn't have recurrent thrush. I didn't have all the stigma. It's the Halle Berry story that came out today about the was it herpes that she was supposed to have had. And I get, you go there and you don't know what's going on, and down there as well, it's just especially when you're a young woman and you're at that point, you're just not expecting it, so you just start turning on yourself. And I think it has an effect on intimate relationships as well, because your partner might not understand, and then they can take things personally, turn things. There's a whole host of stuff that, and no one talks about it because they don't know how, and your friends aren't going through it so you can't even kind of balance it out there and be like, oh, that's happening to me too. You just kind of go in on yourself, and you feel very alone and isolated with it, I think.
Yeah. And sometimes that, dryness and pain with sex will lead to so many other things. Sometimes I see women decades after they've started to have issues, and other compounding issues happen with that. The physical pelvic floor dysfunction,
Yeah.
as all the emotional and relational compounding issues that go along with that. I've seen in the comments here, someone was diagnosed with PCOS for over a decade. So just to kind of be clear, when you are getting those symptoms, we're talking about hot flashes and night sweats and anxiety and joint aches and pains, also usually comes with some changes in the menstrual cycle, usually some lightening or some um, decreasing frequency or irregularity of the menstrual cycle. Sometimes the menstrual cycle goes away. And then, as you mentioned, FSH and period history. So, what's happening with menses and the FSH level? And if the FSH level is high and the periods are pretty much gone, that's a diagnosis of premature ovarian insufficiency. But so much is going on prior to that point, and so much is going on around that. So I think that's really important for our viewers to know if those things are happening. Continue to raise the topic. Could this be premature ovarian insufficiency? Our lab tests, because with PCOS, of course, FSH would be normal, but with premature ovarian insufficiency, FSH would be elevated because, and I'll just explain a little of the physiology. It's the FSH from the brain that's telling the ovaries what to do. And if the ovaries aren't listening because they're having one of the insufficiency problems that we just talked about, then the FSH is going to keep driving. It's going to go higher and higher and higher, trying to drive those ovaries. And that blood test is part of the diagnosis. But we know that there's many other parts of the diagnosis, not just number from a lab. And so let's address the fertility and just make sure people understand some of those aspects. Do you want to start?
Yeah, so I mean, again, I didn't know very much when I got diagnosed, so I did the thing that you shouldn't do, which is Google, and then Google tells you. even though I know, like I tell my patients that you shouldn't do that, but it's the first thing you do is Google, and that's when I kind of started panicking. So I went to see somebody. So if you have POI, you aren't necessarily infertile. Your fertility is decreasing because obviously your ovaries are producing the eggs, and with the estrogen, if the estrogen goes down, the eggs aren't producing. But you can have, from what I understand, you can have fluctuating kind of courses. So you can kind of go back a little bit into fertility kind of waves where you become a bit more fertile at times. But ultimately, you if you go through the menopause, which is part of the stage that you can get at, once you've gone through the menopause, and you are unable to have children. And one of the tests I had with my diagnosis was a test to see how many eggs were left, and that showed for me that there were no eggs left. So I know that I've probably gone through that. So for me, the option of having my own biological children isn't possible anymore. But I know that isn't necessarily, that's not the same for everybody, and there's just, as we were saying before, there's so many different factors pouring in. It's really important for people to get checked in themselves, because it's not a blanket rule for everybody. And
Yeah. Absolutely. Thank you. Yeah, thank you for clarifying that. So, and that kind of raises the conversation about birth control, because not everybody wants to get pregnant. And I think it's really a courageous decision for people to make a decision not to have children. And I've been an obstetrician for 25 years, and I always am inspired by people that say, it's just not what I want to do, whether it has anything to do with premature ovarian insufficiency or just a conscious decision. And so not everyone wants children. And I think for people who are having premature ovarian insufficiency or reduced ovarian reserve, we need to make sure contraception is available for those that don't want children, and that can't be forgotten. And I think a lot of providers forget that part. And then for people who do want children in this situation, there are options. And I work at a fertility clinic, actually separate from Pandia Health, Chicago Center for Fertility, which is in Michigan in the US. And I see patients all the time who are looking for, options. Options would be eggs, donor embryos, gestational carriers like a surrogate. So we are managing people who have decreased ovarian reserve with really great options for carrying their own pregnancy or having a beautiful, healthy baby.
Yeah. And it's hard, because I remember, I mean, even though all my eggs are gone, I think when I saw the specialist, he did say, but because you've got POI, because you've got idiopathic POI and we don't know the cause, that sometimes that's the one where you can sometimes have a fluctuation. So he was talking about, but then we had to have the conversation about contraception because he was like, you need progesterone as part of your HRT, and part of doing that, you could either take it or you could have it as the Mirena coil, but obviously that would be contraception. But then it's hard, isn't it? Because I was at that point where I was like, well, I'm not in a position to have, I know my options have been technically taken away from me, but I'm not in a position to have a baby at the moment. I'm not even with somebody that I would consider having that. So I do need contraception because I don't want to have, there's so many different factors coming in, and then you're trying to make decisions about something by yourself. I remember all of the appointments I used to go to at the fertility clinic, it was yes, it was the fertility clinic for everybody. So you'd always sit in the waiting room, and most people, when they're going through fertility issues, are doing it with the partner, and they're normally there because they're trying. So you'd be sat on your own in the waiting room, and then you have to kind of go in and have these conversations about big life-changing things when you're not in that place, but you don't want to rule more options out. It's just, there's a lot going on.
Oh, I can just feel, that sort of the chaos coming out directions. And you highlight so many aspects of what compounds and overlays the medical diagnosis, and it's so much a part of what women go through, and what is often set aside from the physical.
Yeah.
I really, really appreciate you presencing that, and trying to. It's so personal. Like you said at the beginning, everybody's story is a journey and so unique. And so I find myself thinking about some of the ways to speak to some of the things you've said, but for each person it's different. I do want to highlight, it is becoming more important as women are taking on careers and career progression and delaying having their children, related or unrelated to POI, that we do have the ability to freeze eggs. And so, oocyte cryopreservation or egg freezing is an option for people if they decide that they want to do that sort of in their 20s, or, and not to do with POI, but people should know that that is an option. And then once you get to the point where you have to make these big, huge, as you say, life-changing decisions, to know that there are options, but those options aren't for everybody. And I didn't even mention adoption. Yeah. I always have to make sure that we put that on the list for people looking to have a family. But I do see people, like you're describing, like your experience, where I'm being told that these are my decisions, but I'm not ready to make these decisions. And that's where the real compassion comes in, and the support that you provide for people.
Well, I think that's what, when I was diagnosed, I wasn't ready to accept it. And I think I was very much, because suddenly you get the diagnosis and there wasn't much support, and there wasn't really anyone telling me what the options were or what it meant. So I just was like, well, I didn't ask for this, so I'm just going to ignore it. And I just ignored. I was like, I don't want to change. And even with the HRT, I remember, I think I saw a couple of people who were like, oh, you should really take the cream or the patches, and I was nope, don't want to. I'll take the pill, because I've been taking the pill. So if I continue to take the pill, then it's not changing my life. And it was almost a very immature, childish kind of reaction to it. But I just didn't want my life to change. So I think anything that could reduce the change that was happening in my life, I just kind of went along those lines. And that's why I ignored it for about 4 years. And then it was only when I realised that there was so much more to it, that I was like, this isn't something that I should be ignoring.
Yeah. And you say ignore it, but a lot of times for women, there's a normalization in control pill. And I think for our viewers to understand, there are sort of, we either go down the fertility path where we're trying to conceive, and there's the options that I discussed in terms of donor eggs, donor embryos, gestational carrier, adoption. But there's the contraception route. Like, I'm not ready for children. What would be the treatment of the other health effects that come from the premature ovarian insufficiency? You mentioned bone health, also cardiovascular health, brain health, urogenital, vaginal, bladder health, all really that estrogen effect. And so the treatment in addition to lifestyle, in addition to stress and emotional and spiritual health, which important to talk with everyone about: diet, exercise, sleep, stress. In addition to those things, really supplementing or replacing that estrogen is vital for those organs and bone health. And how we do that is either a birth control pill, which is a very normal, healthy way, safe way for women who are young to be taking the estrogen and progesterone. And then there's what we would call menopausal hormone therapy, MHT, which would be the estrogen and the progesterone sort of taken in different dosages. But I think people need to understand that the dosages for someone with POI, someone who's 36 like yourself, are different than the dose for someone, or even the ways that a young woman would want to take it are different than an older woman. Is that of your experience?
No, definitely. I think that was it sounds silly as well. And again, people are doing so many powerful kind of people are posting now about putting the patches on, and all of that's incredible because it is just normalizing it. Because when I was going through, I was like, well, I'm the only one who's gone through this. I don't know anyone. I don't want a patch on me to show that I don't want to be at the beach and there be a patch on my bikini line. And then, I mean, the cream as well, even things like you need to get into a routine with the cream. And I'm so bad at my face care regime.
Right.
I was like, how am I going to do if I can't even stick to a face care regime? How am I going to stick to like moisturizing estrogen that I need every day? So I think for Patamage, just for I was used to taking the pill. It was by my bed. I was just like, so I can just take this HRT pill and it's just by my bed and I'll do that. And I'm still, to be fair, like I'm better now. But again, at the start, I wasn't great because the pill was always just I don't know, it doesn't feel like a medication as much, does it?
Right.
Just like the pill, you're just taking it because it's the pill. Whereas actually you need to switch that mindset because you do need these hormones. Otherwise there's going to be a lot of kind of other effects as well. So there's a lot of psychology behind it, really.
Yeah, and that psychology is kind of what I was alluding to with, the pill is a very, very good option for premature ovarian and young women. It's great dosing. It's normalized. You can pull out your pack and take it. Nobody would ever ask any questions.
Yeah.
And so it's a really good option.
I think that was it. Even like if I've got it on the side, no one's going to think that's abnormal because they'll just assume it's the pill. They'll assume it's the normal pill. They won't know that it's the HRT pill. So I think it's lots of little things like that. You're like, okay, I can hide this a bit longer.
And the actual birth control pill is a good option too.
Yeah.
That your experience as well. Like it's one of the options.
I suppose I was accidentally taking that beforehand because now I am actually on estrogen HRT pills, but before got diagnosed, I was on the oral contraceptive pills. So I suppose I get it because it was masking the symptoms. So I have almost been treating myself for quite a long time before. So it's really hard to know exactly when everything happened. And then I had to have all the bone scans and blood tests and things when I got diagnosed, and thankfully my bones are fine at the moment. So it probably is because of taking the contraceptive pill previously. So I've always been treating myself for something I didn't know I had, which is interesting.
And I can sense and sort of summarize that: birth control is a good option for this. Menopausal hormone therapy in a pill or a patch. I mean, there's many regimes that we can kind of customize or personalize to what someone needs. But I can sense that there may be people listening who are thinking, well, if I'm on a pill, do I have POI and how can I go? And so those are also things that we can walk through. And so I'm just thinking, speak with your provider. From a perspective, I would propose, if you're really worried, come off the pill and have fertility, those kinds of things. But we do know, like you said, about 1 in 100 under 40, 1 in 1,000 under 30. So you're not alone. It's not isolated. It's also not super common for really kind of panicking about at this point.
I think I don't know. I think possibly the reason we haven't, because like you mentioned before, women are working, the careers are taking longer. I think women are having children later or trying to have children later. So I'm sure that there's a lot of people who in the past were missed because they maybe had their families in their early 20s, and then it didn't really matter. No one thought about it, the symptoms wouldn't have been considered because they were women. Women's health has never been given that much kudos. So they probably just struggles through some of the symptoms. So I think that's why it's probably exposing itself a little bit more now, is because women are having children later, and unfortunately fertility is the thing that a lot of the time I think probably doesn't mask it in a lot of people, because it's when maybe they're having issues with that they realize, or when they come off the pill, that things start to show themselves.
Yeah, absolutely. And I do see younger and younger women really advocating for their, again, thanks to information that's out there like your book and what you're doing, because women will come in and they'll say, like, I just want to know what my ovarian reserve is like. I just want to know that I have options with fertility. And then they may progress to freezing eggs or going away for a year and coming back to be evaluated. And so those things are definitely available. I'm going to turn to some questions. I don't see a lot of questions, except maybe just a couple. I don't know if we have somebody at Pandia that wants to put questions in, but the questions that I did see were regarding AMH, so anti-Müllerian hormone, and then someone asked about eggs on ultrasound. So I'll just sort of clarify with that. With someone who wants to know their ovarian reserve or is having symptoms and wants to be evaluated, there's the period issue. Periods going away. There's the symptoms that Siobhan was talking about. There is the FSH test, and then there's an AMH test, which would be low because it's a marker from the ovaries about egg quantity. And then there's something called an antral follicle count, which is an ultrasound sort of looking at how active the ovaries are, because ovaries actually produce eggs every month. It's kind of job. We're born with the eggs that we will ever have, and then we sort of ovulate them one a month, depending on how healthy the ovaries are, and we can kind of see those follicles coming to maturity on the eggs on the ovary if the ovary is active. So that's called an antral follicle count. And I see another question, how should we be getting bone density scans? So that would be a DEXA scan with your provider. And if you are having premature ovarian insufficiency, that lack of estrogen can lead to bone thinning. But like Siobhan was mentioning, being on a birth control pill protects the bones. Being on menopausal hormone therapy protects the bones. And so that's part of the treatment process. Do you have any more comments on that? And I'll just keep watching for more questions.
Yes, no, so I've only had one so far. I think that was 5-6 years ago, and I've not heard anymore. I'm guessing I'll need another one soon, but I've not I've not heard about when I next need one. Probably need to check in with my doctor at some point.
Yeah, and I think again, being on the estrogen and progesterone is protective, so it's less concerning now that you're that you're aware of getting that treatment.
I think that's I think the one thing I'm more aware of, because I know that like weight bearing exercise and stuff is really important now as well. I think that one of the difficulties is when you're at this point in your career and you're working a lot, and it's hard to find the time to do all of those things. So I'm very conscious as well that I'm not possibly always eating as well as I should and exercising as much as I should, just because you've not got time, and then you feel guilty about it as well. So it's another layer to
this. We as women can feel guilty about so many things, right? Yeah, and you mentioned exercise and certainly diet, which I'm in the US, I'm Canadian, but I live in the US, and our North American diet is not great. But supplements can be important, making sure people are getting vitamin D and calcium, some of the multivitamins, nothing weird and wonderful, but something to actually replace dietary deficiencies is really vital, because your body is an orchestra of beautiful hormones, and that's what's going to nurture your bones and also your heart and brain and everything else. So yeah, I would just encourage everybody that's listening to go over and follow Siobhan on Instagram, but also can you tell us a little bit about your book or how people can get to know more about your work?
Yeah, so my book's called My Life on Pause, and it's on Amazon. It's just if you Google My Life on Pause, so I've got looks like that. It's just on Amazon. It's also on a few different bookshops on if you type it into Google. It's just kind of my own journey through diagnosis and finding out, and then just some of the issues that I felt I had when I was diagnosed, because I think a lot of people, well, no one really talks about it and nobody really knows what to say. But a lot of the things that I was worried about were things like dating, meeting people. I felt very broken at the time and had quite a toxic relationship with my body for a while, where I felt very betrayed and let down. So it took a while to kind of build that back up again. So it's just kind of talking about all of those, just some of the feelings that I was feeling that I felt nobody else was speaking to me about. Just because there might be one person out there who's also feeling like that. And I just wanted it to be, as I said, everyone's journey is very different, and it's not, the book's not there to be like, this is how you should feel. The book's just there to be like, this is how I felt. Maybe you can relate to it, maybe you can't. But seeing as there's not very much out there, I think it was just nice. I just wanted someone to have something, because I felt that there was nothing when I was kind of diagnosed.
Yeah. Oh, so powerful. Siobhan, thank you for sharing your story in such a powerful way. It's a resource that I will definitely be offering to people, because like I said, even as of yesterday, I was seeing women who would benefit from knowing that they're not alone, and that level of compassion and understanding and support that they receive from knowing that you've been through this, and that you're able to offer that I want to say love to them. And we're getting some comments that the book is brilliant, that people have just received it. So Selena Carvalho's just received it this week. That's fantastic. Brilliant book. Oh, this is so cool. People have read it. It's so good. Thank you so much. And I would just, again, encourage people to follow Pandia Health, to sign up for our VIP, to kind of do the health assessment and have an opportunity to have a provider review some of your questions and concerns around early menopause, and some of the options for treatment around early menopause. And I will take this short live that we've done and put it in my newsletter, which will be on drcatherinehansen.com. So I'll be putting out a newsletter in the next while, and we'll recap some of the highlights from today. So follow me, follow Pandia, and follow Siobhan. And do you want to just share your handle?
Yeah. So it's based on the book, it's MLOP_POI. So My Life on Pause, but it's MLOP_POI.
MLOP_POI. Awesome. And I started following you just recently, so, and I love your work. I absolutely do. Thank you so much.
Thank you. This has been lovely.
Stay in touch. Let's stay in touch.
Well, so it's nice kind of speaking to people as well, like we're different countries, like, but everyone, that's the thing, everyone's going through this around the world. And I think it's just such a missed group of women, and just the fact that there's not much out there. I think there's so many women who are suffering with this, and I think having conversations like this as well, it just opens it up, and it's just an opportunity to kind of connect and get the message out there.
A nice big global worldwide hug for people. Thank you so much. Have a wonderful day.
Have a lovely bye.
Bye-bye.